Hello, and thank you for joining. I'm Pardis Nurzad, and I'm here with Rebecca Ismakov to represent the data science team at Carbon Health. I'll talk about the data science team infrastructure, roadmap, and some of our current and upcoming projects and responsibilities. Rebecca will speak in detail about her recent outbreak risk assessment project for helping businesses bring employees back into the office. Last year, our number one priority on the data science team was to build a reliable, scalable, and secure infrastructure for data at Carbon Health. We invested in a dedicated data warehouse, tooling for building integrations to move data into the warehouse from multiple and varied sources, a BI tool with built-in support for ETL pipelines and Python, and tooling for real estate and geodata analysis. In the diagram, you can see what our implementation looks like. Snowflake allows us to perform complex analyses over all of our data with ease. Fivetran helps us reliably build integrations with varied data sources, as you can see. Periscope has been a great BI tool for us. It enables building good-looking dashboards, but more importantly, it has helped us build detailed analysis reports that we can directly share with our stakeholders. It allows us to further refine our analyses and build models in Python. It allows us to build ETL pipelines and monitor their performance and dependencies. All three tools have allowed for important security features as well, and empower our security team to further build towards our goals in protecting patient data, both internally and externally. I'll talk about the data science roadmap. We grew from 2 to 6 plus 1 part-time data scientist. We continue to grow the team through 2020. Here are some of our active or upcoming projects. Number 1, site suitability assessment and ranking. We want to be able to answer 2 types of questions. First, given the current volume at each of our clinics, which other areas of the US are potentially good locations for future Carbon Health clinics? And second, given a list of properties in a neighborhood or city, what is a good ranking of the locations such that the real estate team can then determine their priorities, since they're spending a limited amount of time in every city? Number 2, wait time estimation. For patients coming into our clinics, whether with a pre-existing appointment or a walk-in, we'd like to provide an accurate estimate of their wait time to present in the Carbon Health patient app. Number 3, capacity planning. As we grow the number of clinics at Carbon Health, we'd like to automate planning for staffing at our various clinics based on the time of day and month of year trends. These next 3 items are projects that Rebecca and I will cover in the rest of the talk, namely our clinical decision support system for diagnostics, the building of covidclinicaldata.org, and many clinical data analysis efforts. Other tasks that we have on our roadmap and continuing to work on are metric design and implementation for clinical excellence in primary, urgent, and virtual care, metric design and implementation for billing and finance across all Carbon Health services and all of our operations. And finally, opportunity sizing for prioritization of company investments. We have yet to build out an experimentation platform at Carbon Health for the provider and patient apps. What we currently have on our roadmap is to identify ways we can avoid the need for an experiment by running observational studies on existing data. However, in 1 to 2 quarters, we'll be ready to start investing in automating an experiment assessment pipeline. So I'd like to begin with, talking about our efforts in publishing the first ever open clinical data set. This one contains the clinical characteristics and X-ray findings of COVID-19 tested patients. The data repository, along with the data dictionary and some notebooks for data prep, are all available at covidclinicaldata.org. The data has been live since April 14th, and we're updating it as we go. The hope is that it can accelerate information sharing among frontline healthcare providers and facilitate studies on COVID-19 tests, signs, symptoms, stages, and care plans. This work has been in collaboration with Braid Health. The team at Braid Health provides us with X-ray results and links to the associated images for some of the COVID-19 tested patients. We surface some demographic data and test results. We include epi factors like whether the patient is working in a high risk of exposure occupation. We include a wide range of comorbidities, include vitals, that are collected by a physician during the appointment. Things like temperature, pulse, blood pressure. Sometimes we also run rapid flu and rapid strep tests, and we include those. We add some clinician-assessed symptoms like labored respiration, and also patient-reported symptoms like headaches, shortness of breath, and the severity for each. And also days since symptom onset, which is important for some of these studies. As mentioned, we also include X-ray results and a link to the images for further image analysis. In order to determine which fields to include and how to read and interpret the raw data, we work closely with our medical team of experts. In addition, we went through many of the observational studies run since December on COVID-19 and other respiratory viral disease. We wanted to make sure that the data would be useful to research teams as is. And one of those considerations was to ensure that we're including all confounding variables that could affect conclusions drawn from the data. For example, a metric that everyone has been talking about is the difference in effectiveness per swab type or test type. For such a study, we need to control for location that affects community prevalence, date range that affects prevalence, and admission criteria that, of course, affects positive rates. We ensure HIPAA compliance. The only date we include is the batch date, which suppresses all the dates of the week to the date of the Tuesday of that week. We add noise to the age to further anonymize the data so a patient wouldn't be searchable via their age. We join the data to radiological findings from Braid, and we send them our noisy age numbers, and they update the landing page for each image to reflect that approximate age. Along with version 2, we shipped a data dictionary. This helps make sense of the data and also helps our contributors if they wanted to contribute to this open data set. Now, the great thing has been that covidclinicaldata.org has, helped us internally and both externally run some studies. In one of the studies, we wanted to investigate and compare the reliability of the various COVID-19 swab types and to validate those with highest sensitivity and specificity. Some swab types and sample collection methods are convenient for patients, and so we wanted to determine if there were reliable alternatives that could provide a better experience. Furthermore, some tests provide rapid results while others take at least 3 days or more in some cases, making it very frustrating for patients. Therefore, we wanted to understand whether rapid tests were as reliable as the alternative COVID-19 tests that were available. Now, due to the cost of tests and limited test availability, using multiple tests on one patient was not feasible. This meant that we could not run a controlled study. So we used stratification to control for the confounding variables that we were able to identify. Of course, this meant that we had to wait longer to gather enough data to reliably estimate results. We are in the process of publishing the results of this study, actually led by Rebecca. Another interesting line of research that this data has enabled both internally and externally has been COVID-19 symptom analysis. Studying the symptoms of COVID-19 was the goal of building the data repository in the first place. Omer Koren's team trained a random forest model showing that given a patient's vitals and symptoms, the model can effectively rank patients who are more likely to test positive for COVID-19. We're also working on identifying the symptoms that are most indicative of COVID-19. Now, this information helps determine whether it would be best for a patient to stay home in the absence of a test, which is very valuable at the moment. Now we'll go on to the, talking about the clinical decision support system. In the early days, Carbon Health was built around two services, the provider side and the patient side. A patient can create an account, enter their medical history. A patient can book an appointment for a particular chief complaint and answer further questions about their symptoms. During an appointment, the provider can see a rank list of potential diagnoses based on the information entered by the patient. Of course, the provider will then ask their own clarifying questions and measure the patient's vitals. At this point, the provider will either choose the correct diagnosis off of this rank list, this suggested rank list, or search for the diagnosis to choose from another search results list. The rank list of suggested diagnoses is powered by Carbon Health's clinical decision support system. All of this work is to reduce provider fatigue and burnout that is common for primary and urgent care providers across the world. Our approach is to create feature vectors based on a patient's gender, age, medical history, the response to the step-by-step questionnaire, as you can see in the slide, available at the time of booking the appointment. Now, each chief complaint has its own custom questionnaire, and a chief complaint is the reason the patient is coming in for an appointment. It's the problem at the time of admission. The training data are the correct diagnoses of the various scenarios and combinations of patient comorbidities and questionnaire responses collected over many years. A Spark MLlib decision tree is trained per chief complaint. We chose decision trees to be able to handle categorical variables, but more importantly, to be able to train explainable models. We'd like to be able to show our providers how a certain decision was made. We want them to be able to look under the hood with just a few clicks. The output of each tree is the probability that a combination of comorbidities, vitals, and symptoms is indicative of a particular diagnosis matching an ICD-10 code. What is ICD-10? It's the 10th revision of the International Statistical Classification of Diseases and Related Health Problems, a medical classification list by the World Health Organization. We use it to uniquely identify each diagnosis for each and every ICD-10. Providers at Carbon Health have put together procedure notes and treatment plans that are then surfaced in the provider app when a particular diagnosis is chosen, again, to reduce fatigue. Now, all models are run in parallel for every new appointment. We filter out all appointments with all outputs with low probability. The remaining outputs or diagnoses probabilities are then sorted and presented to the provider at the time of the appointment. We use Spark and Scala to implement the models that power the clinical decision support system. Once the model is trained, it is exported to MLeap and deployed as part of the Carbon Health Provider app. MLeap is a serialization format and execution engine for ML pipelines that are built in Spark, scikit-learn, or TensorFlow. Now, there are many areas for improvement. The feature vectors are quite sparse, as they need to represent every single question ever created in the questionnaires. And we'd like to use compression methods to speed up training time. Most tuning is currently manual, and we would like to build a more automated approach to this. We'd like to develop a way to measure concept drift in our data to come up with the right cadence to retrain the models. We'd like to improve our assessment criteria based on the different diagnosis groups, because a mistake in one is not equal to a mistake in another. And then rather than training separately for each ICD-10, we're considering training for ICD-10 groups or clusters to take better advantage of the data and make up for sparse data in some diagnostic clusters. Now, these are just some areas of improvement, and there are many more. I'll now pass the Zoom over to Rebecca to give a detailed overview of her fantastic work quantifying the impact of various business policies on the risk of an outbreak.
Thanks, Pardis. So for this next portion, I'm going to talk a little bit about the risk assessment project that we here at Carbon Health did for our COVID Ready program. So first, what is our COVID Ready program? So basically, we're helping businesses get their employees back into the office. But before we do that, we want to make sure that we're doing it in a safe way. So one way to check for that is we created a risk assessment model that basically tries to score the risk of a given individual contracting COVID-19. And then we can use that based on certain constraints that the business may have, budget constraints or limited number of tests. We can then use it to assess other appropriate testing cadences, decisions around quarantining, et cetera, for businesses looking to safely bring employees back into their office. So the way we did this is we created a simulation to observe how good we'll be at stopping outbreaks in the office by playing around with various parameters. So a little bit about the simulation and the algorithm and how it works. So basically we start with n number of simulated employees. And we start by introducing some initial infections. And this will depend on the I initial parameter. We then introduce symptoms into the simulation. These symptoms include both COVID-19 symptoms as well as COVID-19-like symptoms, which may be due to the flu or other respiratory illnesses that show similar types of symptoms. We then introduce self-imposed quarantine, which means a certain percentage of people displaying symptoms will choose to self-isolate. This will depend on the risk behavior parameter. So, in real life, we would ideally hope that everybody's remaining home if they're showing symptoms, but due to maybe misdiagnosis of symptoms or various reasons, not 100% of people will. Then we run tests on select number of cases, we receive test results, and then certain infected number of cases recover and some susceptible cases are infected. And then we repeat steps 2 through 6. So one thing is that we needed to determine, both for the simulation also in real life, is how do we decide who to test? So to determine this, we did a few different filters. So one is basically depending on the prioritization method. This includes testing symptomatic first, asymptomatic first, or just randomly selecting. So basically not giving priority to either case. Then we choose not to test cases that have been recently tested. So we'll test depending on the testing interval parameter employees every X number of days. Also, we do not test cases that have already knowingly recovered, meaning if somebody had COVID-19, they quarantined, and then after some time they got a negative result, for this simulation, we assume that they're not going to contract COVID-19 again. And then if after all that there's still some additional tests available, then we'll randomly select from the employees that are left over. So what are some of the things that we wanted to use the simulation to check for? So one thing is we have different types of tests for COVID-19. We have PCR tests, which look for pieces of the virus to determine if somebody has an active infection. And this test includes both rapid versions and non-rapid versions. And then also we have antigen tests. And these work similarly, except they look for pieces of the protein instead of the protein themselves to determine if someone has an infection. So what are the differences and kind of the pros and cons of both of these different test types? So for the PCR non-rapid test, they're believed to be a little bit more reliable, meaning they provide greater testing sensitivity. However, they take a longer time to deliver results. And unfortunately, the greater number of testing, the longer it takes, because if they get an influx of tests, then that creates bottlenecks. Then for the antigen tests and the PCR rapid tests, they deliver results really quickly within 15 minutes. However, they're believed to be less reliable, meaning they return a greater number of false negatives. So one thing we want to check is what's preferable. Is it better to have greater sensitivity or faster turnaround times? So there's some studies that have already looked at this. So as a first step, step one, we just wanted to reproduce these results first and see kind of what our simulation shows us before we played around with the other parameters. So some of the parameters that we throw into this model, the simulation, is testing interval, which I mentioned before, is how frequently we want to test employees. Beta, which is the likelihood of someone being infected inside the office. Gamma is the recovery rate. There's the external infection rate, which is the likelihood of being infected outside the office. Risk behavior, which is, like I mentioned, the likelihood that somebody will choose to stay home if they have symptoms. Again, both COVID-19 symptoms and COVID-19-like symptoms. And testing process, which is how we prioritize who to test first. Random, symptomatic first, or asymptomatic first. So as a first step, we just threw in some default values into the model, which included testing interval of 4 days, beta of 0.2, gamma of 0.07, and et cetera. You can see here the values that we used for initial testing. So the parameters for the antigen or the rapid PCR tests, we use a test sensitivity of 0.75 and a testing delay of 0 days, since it returns results in 15 minutes. For the non-rapid PCR test, we use test sensitivity of 0.98, but a testing delay of 5 days. And it should be noted, though, that in reality, this testing delay may be even longer, sometimes 6 days, some days up to 8 days. So a little bit, some information on the model. So we ran the simulation through 25 iterations of each configuration type, and then we looked at the average number of cumulative infections for every day for a given time period, depending how long you want to look. And then we're able to use this method to kind of compare different configuration types and play around different parameters. And then once we plot the results, see which one results in less cumulative infections, aka which one's more preferable. So again, the first thing we looked at is PCR versus antigen, or in general, greater sensitivity or faster turnaround times. And as you can see here in the results, we find that actually antigen tests perform better, meaning they result in lower number of cumulative infections for this 130-day window that we're looking at. So basically what this says, that sometimes it's even preferred to have lower sensitivity if it means faster turnaround times. Then next, what we looked at is how testing cadences affects transmission. So we looked at testing every 2 weeks, every week, every 4 days, 3 days, 2 days, and every day. And not surprisingly, as you can see here, the more frequently you test, the lower the transmission rate is. So yeah, so basically you see less outbreaks in the office. However, in the first 2 cases that we were looking at, we were basically randomly selecting who to test first. We know that in reality that people with COVID-19 are likely to show symptoms. So I decided to check what will change if we decide to test symptomatic first. So as you can see here, if we test symptomatic first as compared to random selection, the transmission, the number of cumulative infections after the 130-day window drops from 84% to 50%, which is a pretty big drop. So for the previous examples that we were looking at, we were, however, assuming that everybody's coming into the office regardless of whether they're showing symptoms or not. Hopefully and ideally, we hope this isn't the case, and we hope that people that are showing cough or fever, etc., will choose to remain home. So as the next step, we decided to look at how remaining home and self-isolating if you show symptoms, how that'll affect transmission rate. So we looked at 0% of people staying home, 25, 50, 75, and 100% if they show symptoms. And here we actually got a really dramatic result. If you look at this plot, we see that even if just 25% of people stay home, after 130 days, it drops from 86% to 20% of the office infected. And again, this is at just 25%. So this is a pretty dramatic drop. And we kind of see that people choosing to self-isolate, they show symptoms, is even better at stopping transmission in the office than testing more frequently. And this result remains true even if we test symptomatic cases first instead of randomly selecting. So looking at these results, I decided to go back and look at the PCR versus antigen thing again. Here using risk behavior of 40%, meaning 40% of people who show symptoms will choose to remain home. And even in this case, when 40% of people are staying home, antigen tests result in less cumulative infections than PCR. Meaning even here, it's better to have faster turnaround time, even at the expense of lower sensitivity. However, at around 60%, it tends to level out, and PCR and antigen tests tend to perform similarly. After 60%, PCR tests tend to perform better, meaning if enough people choose to stay home, if they show symptoms, then it is better to have greater sensitivity, even if it takes a little bit longer for results to come back. And this kind of makes sense if it's taking longer, but people are remaining home, then they're not going to be infecting others. So basically, in summary, some of the things we found that shorter delay of results delivery is preferable even at the expense of decreased testing sensitivity, at least up to a certain risk behavior percentage. Increased testing cadence decreases transmission rate. Individuals with symptoms isolating themselves decreases transmission rate. This result was actually our most dramatic result, an interesting result. So this kind of just shows how people showing symptoms should do their best to remain home if they can. And in cases where individuals' symptoms are unlikely to isolate themselves, it's preferable to test symptomatic cases first. So some of the next steps, what we want to do with these results. So we were hoping to create a web app that will allow business to kind of put in some of the constraints that they may have, some budget constraints, some limitations, and then play around with other knobs such as testing cadence, testing policy, and see how that will affect their transmission rate. So that will allow them to make better decisions and make sure that they're being safe. So those are just some of our findings and some of the things we looked at. If you have any further questions or want any more information, you're welcome to email us at datascience@carbonhealth.com. Thank you so much.